All right, good afternoon. We're going to start our lunch session. We call it a lunch session because we're glad you found the food, and this is where we're eating and connecting and re-engaging. We will have 2 more breaks on the other side. We'll have a break on the other side of the lunch session, another break mid-afternoon for refreshments and visiting the exhibit hall. I want to thank you all for showing up and making our 26th annual Business of Pediatrics program such a success. All right. We have a couple quick announcements. We want to thank our presenters, half of whom you've seen already, and the other half you will be meeting this afternoon. And you've got the agenda in front of you, and as I said, there'll be 2 more breaks, but part of our goal here is helping all of our pediatric practices learn and be more successful, and learn from each other, not just from the podium. We've mentioned to folks you can get your CME credit. Look at the back of the agenda, and there's information about how to get the CME credit. If you need help, stop outside and we can help you. Where are we on parking vouchers? There will be vouchers or the gate will be up, something like that. But parking should be free. And bathrooms are at the end of the halls, and if you need help, just ask someone from our Pediatric Health Network team. So this next part involves a little bit of technology. Hopefully it'll go okay. As some of you may know, we actually are part of Children's National Hospital, and they are one of the key hosts for today's presentation. What you may also know or not know is Dr. Kurt Newman retired as CEO of Children's National, and Children's National has a brand new CEO. She is from Houston, Texas Children's, and her name is Michelle Riley Brown, and she's smart, personable, and knows her stuff. And with that, she actually recorded a short announcement, which we're going to bring up, a short welcome.
Hi, I'm Michelle Riley-Brown, President and CEO of Children's National Hospital. I'm delighted to welcome you to the 26th Annual Business of Pediatrics, sponsored by the Children's National Pediatric Health Network. In my 5 months at Children's National, I've connected with healthcare staff, providers, and community partners across the region. Your impactful work as part of the Pediatric Health Network is helping us focus on quality outcomes and delivering efficient, affordable, and coordinated care to our patients. Your commitment to providing exceptional care is evident. I look forward to continuing our work together to ensure every child and family receives the comprehensive and compassionate care that aligns with what we would want for our own families. Thank you for all you do.
And as a smart CEO, she's learned how to be brief. So, all right, can we, yep, it's all good. You can keep eating. All right. Some really quick updates. We're not going to beat this all to death. We're going to talk a little bit about our health network. Dr. Lee Beers, one of the past presidents of the American Academy of Pediatrics, is going to give a brief update on some of our behavioral health work. Rachel and Melissa will talk about our practice administrator group, and we'll be ready for our lunchtime presentation. So we launched our Pediatric Health Network to bring practices together to improve care and improve contracting. And we're continuing to grow up to 63 practices and over 600 primary care providers. If you want information, just stop at the desk outside. The work we've been doing, developing more pediatrician-friendly and favorable payer contracts, implementing a robust data platform across all our practices, 5 different EMRs, and we can now get data from all of them and use it to improve care and payment. Formal legal attestation as a clinically integrated network, so we can push back to the payers when they say, who are you and why should we negotiate with you? And most importantly, leadership that is not simply 1 or 2 folks from the hospital, but actually represents, we have a board and well over half the board are practicing primary care pediatricians and champions from right here in our 3-state community. So this is our strength and our secret weapon. And thank you all for helping. And with that, I'm going to bring up Dr. Lee Beers. Lee's a pediatrician at Children's and part of our pediatric health network, and preceded Sandy as one of the AAP national presidents. So Lee, take it.
Perfect. Great. Thank you very much, Mark. Great to see everyone. I'll be here today presenting on behalf of myself and Dr. Satullo, who some of you have met before at previous meetings. Just to give you a little bit of an update on the behavioral health initiative that we have going on with PHN. That's been that we started about a little over a year and a half ago. I guess first thing is at some point we have to come up with a catchier name, that behavioral health initiative. So if anyone has any great, fun ideas, you can let us know about that too. So just as a reminder, a little over a year ago, we started this initiative with the purpose of really helping our PHN practices to develop a comprehensive strategy to address mental and behavioral health needs within the regional practice network and within individual practices, really recognizing that there's not a one-size-fits-all solution. Every practice looks very different, facing different challenges. The medical providers and other staff in the practice have different comfort levels and levels of education with mental health, and so we know there's not a one-size-fits-all solution. And as we talked with all of you and really dove into the literature a bit further, we decided to focus on 2 key areas. One is education, training, and partnerships, and the other is integrated business models and care management. Some of you have participated in some of our educational initiatives already, but just want to tell you a little bit about what's coming up next in the new calendar year. So first, on the side of training and education, we're going to be relaunching our free virtual behavioral health webinars and office hours led by our experts in child and adolescent psychiatry. They're open to all. You should have gotten some emails inviting you to register for those things. If you have a chance, please swing by. We have a table in the exhibit hall. And Dr. Laura Willing, one of our child psychiatrists who will be hosting the office hours, is there, so you can meet her in person and get to know her a little bit better. So we'll be doing those once monthly on Wednesdays. So first webinar is January 10th, and please save the date. The second piece that we're going to be working on, this is something a little bit new for us, but we're going to be working on a year-long QI project, and it's going to be a different kind of QI project, not a QI project focused on a very specific, discrete clinical measure. But what we really are going to be doing is working with practices to improve your site's entire system of integrated behavioral health care, including free coaching with our CHN and PHN, CNH and PHN, integrated behavioral health experts. We are going to start with an initial pilot cohort where we're probably going to have some, or we are going to have some limited capacity to do that because we want to make sure that our experts are really available with you to sort of identify at what stage of integrated behavioral health care you're at, where you want to go, how you want to get there, and really work with you to expand the capacity of your practice in the way that really fits your needs. We are right now recruiting an initial cohort of PHN sites, and from that we'll select our first cohort and hope to continue that on into the future. So again, please, we'd love to have you. If you have any other questions about that, actually Charlotte and then one of our other team members, Charlotte is Laura, and one of our other team members, Julia D'Angelo, is at the table and can answer any questions that you may have on that. And we would really love to have you participate. And if you are interested in either of those things, here are QR codes. You can also get those at the table. We've got some postcards, other ways that you can register. So we'd love to have your participation and your feedback. Thank you all.
All right. Now I am thrilled to introduce leaders, practice leaders, and I would venture that in your busy pediatric practices, among your practice leaders are your office or practice managers. And it's not just we as pediatric clinicians who are learning from each other, but it's our office staff and leadership staff who are learning from each other as well. So I'm actually thrilled to introduce to you Rachel Baker-Smith and Melissa Graves, who are practice administrators and co-chairs of our practice administrator group. Say, Rachel, Melissa, tell us more about it.
Hi, everyone. So the committee that we're on, the Practice Administrator Committee, is a group of 12 within the PHN that we meet periodically to share best practices, as well as let the PHN know what challenges we're facing for groups large and small. In general, the PHN really values our input for problem solving, as well as coming up with topics for events like BOP. And so now we're at a place where we don't want to just keep all the great collaboration to ourselves, but we really want to expand to other managers and administrators in the area. So to do that, you got it? Awesome. So if you're an administrator or manager, you can become part of a larger virtual community. We hope to do quarterly meetups, and we can forge valuable connections with one another, as well as share and learn industry-leading strategies to help make not only your practices successful, but yourself as individuals, and really get better networking opportunities. And then, if you want to tell them how to sign up?
Yes. So please join us and come visit us at our table over in the exhibit hall if you are interested in joining up with this group that we're trying to bring together. You can just come give us your email and we'll connect with you and get you all signed up for this group going forward. Something we're going to do right now that is going to throw this off just a little bit is we, as a practice administrator committee, would like to recognize two people in this room today who have been more than a large part of why we are standing up here. And so to start, I'd like to ask Dr. Weissman and Jody to come up to the stage, please. They're not going to be happy that I'm doing this, but that's okay. Melissa and I, on behalf of really everybody in this room, it's no secret that Dr. Weissman has been a large part of all of our collaboration and success in this room. He epitomizes community, bringing us together and really valuing the ideas and the opinions of everybody in this room, particularly practice administrators. He has valued our opinion, he has brought us together, and in large part, the Practice Administrator Committee and this PAG is being formed because of his value to us and his ideas and his desire to be better as a community. So we thank you very much for all that you've done for us. And to Jody, if you have not met Jody yet in person, she is our sunshine day to day. She is who we reach out to when we need things. She does a lot of behind the scenes things, and she really is also the epitome of helping us bring things together on a day-to-day basis and joining and bringing this pediatric administrator group together. So thank you so much for everything.
Well, that was unscripted. I've learned over the many years is, one, Find really smart folks, passionate champions like Rachel and Melissa, try to get them the support and then get out of the way. And so that they can help be successful. And I mentioned this at other meetings, look around. We are a pediatric community, but we are so busy in our practices that we no longer really get to connect, socialize, share with each other, learn from each other, but it really is an extraordinary community. And part of the reason we keep doing these meetings is to remind each and every one of us that we are special and we are doing great work for kids and families. And yes, we have businesses to run and payroll and all those important things to meet, but we've got to learn and help each other. So thank you all for being here. And we've now got practice manager champions to raise our game across all the other practices as well. So thanks. Oh yeah, and you know, people are still looking for jobs. And I would say that virtually every one of our practices is looking for staff. We're all sort of struggling filling positions. Our Pediatric Health Network hosts a job board. It's online, it's free. So if you're recruiting for a clinician, a pediatrician or a nurse practitioner, we can post those online. People actually view it, people actually find jobs, and I would say many practices have filled positions based on people who have found the job opening here. So if you're interested about that, reach out to our Pediatric Health Network, stop at the desk, and our goal is to keep this going. It's free. And, you know, otherwise you're out there competing with Indeed and, you know, all these other sorts of places, but that's not really the audience that we're looking for. And then just a reminder, which I alluded to earlier, we've got a great team and we're really thrilled to sort of do these shows, but it doesn't happen without you all. Being engaged, participating, showing up, asking questions, just reinforcing that we're all in it together. And it's really, our goal is a shared success story. And we appreciate you showing up and look forward to seeing you at our future pediatrics clinical program and business of pediatrics program in the years ahead. Oh, and I would point out that's Sue Cressley, another AAP president who's been a regular presenter here as well. So we've got all the all-stars here on the stage and in the audience. And just a reminder, it is the holiday season, and from everyone in our Pediatric Health Network, we hope you get everything on your list. All right, with that, we're going to transition to an interesting topic. It's a little bit of an interactive topic. I want to bring up to the stage Paul Quigley and Brenda Shepherd-Vernon. They are actually part of the hospital leadership at Children's National. Paul heads up security and has a long career in that space. And Brenda helps lead our social work services. And they did a presentation like this a while back for our practice administrators. And it was really well received, and we decided we want to bring it back to a broader audience. And part of it is really, what happens, what are you going to do in your office if all of a sudden something bad goes down? Someone's angry, someone's yelling, someone's acting out violently. Most of us think about it, but hope it never happens, but don't really have a thoughtful approach for how we would address that. And that's what this lunch session is about. It's to talk about some of these settings and give you some suggestions and recommendations for how to think about this in a more proactive way. Did I get that right?
You did. Very
Okay.
well. Thank you.
So with that, Paul and Brenda, give them a round of applause. And I'll be flagging around on stage.
Sounds good. Hello, everyone. Thank you. And if you look at our topic, you kind of think of one of those topics that is a little bit scary, right? It's one of those areas that we don't want to think about when it comes to what we're doing in our business. But it's something that comes to us, all right? It's something that we have to engage in. So we're going to talk about this, and what we're going to do is there's going to be a portion of it that is us talking to you and telling you what is going on in the world, but then we're going to need your interaction to come up with our answers that we're going to have for a group of scenarios. All right, so this is very much interactive, and we'll see how much information we can get today and how much we can work through some of those issues that we all have. Now, to introduce ourselves, though. So I'm Paul Quigley. I'm the Executive Director for Security, Parking, and Transportation at Children's. I'm one of everybody's favorite, not because of security, but because I carry about 50 parking passes in my pocket at any one time. So not validations for here, but for children. So if you see me, flag me down. I'll see what I can do for you. I came to Children's almost 2 years ago from the Department of Defense. I was a colonel in the United States Air Force, and my last position was I was in the Office of the Secretary of Defense, and I was the Director for Nuclear Security. So you say, what does nuclear security have to do with healthcare? Nuclear security is the #2 most valuable resource that we have. Our children are #1. Okay, so on that, exactly, we all agree, right? Okay, and then, Brenda, and I don't know which one goes, she has a better picture than I do, so here we go.
Hi, everyone. As you see, my name is Brenda Shepherd-Vernon. I'm a social worker by training. I've been at the hospital for 37 years, 37 glorious years of actually learning. I started out in primary health care. So I learned a lot about what physical presentations look like, and I also did trauma. So those married very well, and it helped me figure out that I can do a lot. I didn't know that I would be able to think fast on my feet, but I did, and the trauma was very helpful. But what I also learned is about the special and sometimes difficult world that our families go just to receive something called health care. And we take it as a privilege, but for some it is not a privilege, it is a struggle to get there. It helped me develop better attitude in myself about how to really engage and focus on what the family is telling me about what their struggle is, and working with the team to negotiate sometimes what we need to do. It's not a perfect world. Families can disrupt our very organized 15, 20-minute session. But I think if we learn to focus on what the key is, and children are important, it's our greatest resource, and so our families are given that responsibility, and I think it's our goal, our mission, our privilege to help them negotiate that. So we have this presentation of how to do that, and I think everyone can do what I do. Actually, it's not hard.
Yeah. Okay, so what we're going to do is we kind of set the playing field here, and I know this is a lot of words that we put up on a slide, but we just really have to see the stats. In an ever-increasing violent world that we're living in, right? We've seen a 47% increase in violence in some of our healthcare facilities, right, since 2020. That number is huge. That is a lot higher than any other industry that we've seen. So it's one area that we really have to focus on, and we have to make sure that we're doing this right, so we keep our staff safe, so we keep our families safe, and make sure those patients get the best care they can have. Now, a lot of this is happening inside of psychiatric units, emergency departments, pediatric departments. So this is a hospital-wide, right? So they're identifying that it's happening in pediatrics more than ever. And then for national data, this one's always tough on me. 57 nurses, and I'm just going to call out one quarter in 2022, and this quarter isn't an anomaly. 57 nurses were assaulted daily in the second quarter of 2022. 2 nurses were assaulted per hour, right? And then in April 2022, 92% of all healthcare workers experienced or witnessed workplace violence in some way. And when we talk about workplace violence, and at IBM, that's staff on staff. When we look at workplace violence, it's everybody that is coming into our workplace. So that's the visitors, that's the patients themselves, and that's the staff having to work with each other. So it's a different dynamic than a lot of other organizations have. One of the things, though, I want to bring out is some of the stats that we have at Children's. And so at Children's National Hospital, In 2022, we saw a rise in violence by 47%. All right, this isn't on the board here. The other piece in that is we saw a 51% rise in verbal violence. All right, so those rises in violence that we're seeing at our hospital is not different than anywhere else in any other hospitals they're having. We're also seeing a rise in crime, particularly crime with weapons in the Washington, D.C. area. Those weapons we were seeing in our hospitals, and we've actually introduced into our hospital weapons detection systems to identify those things beforehand. These are things that no one ever thought you would have to put in a hospital in the past, but we're doing now. These aren't just in our emergency departments, it's for our entire hospital itself and a lot of our facilities. Some of the things that we've seen that have been the toughest on us when it comes to organizationally threats to us. We've seen threats through misinformation. We've also seen threats through protest activity and direct threats to organizational leaders over things like vaccines and gender-affirming care. But when we look at our stats that we have here that came from a survey that we've done, so we did a survey back in 2022, and in that survey, 38% of the staff reported facing verbal and physical violence at least once in the past 12 months. And when I say staff, it's also not just the staff that's providing care. It's also staff like welcome desk staff. It's the interpreters. It's even the EVS or the janitors that are part of our organization. So we have to pay attention to everyone that is part of the processes of making sure that we'll be able to provide care. And then of those 38%, 55% were nurses. All right, so the people that are providing direct care, direct contact, the people that are putting hands on patients and taking care of them the most are the ones that are being impacted the most. Okay. And some of the things that we should be doing in our own organization. So one of the questions that we're going to have during our scenarios is we're going to talk about physical environment. Do I expect every person in this group to be able to have and go back and look at your organizations and say, I'm a physical security expert, I can go do a risk and vulnerability assessment? Probably not to the level that I can, but I think everybody in this room can call out and say, this is not safe. This is not a safe environment. If I was put into a situation, I feel vulnerable in this situation. So that's that risk and vulnerability, right? So what we do is we have to go back to our workplaces, go back to our locations, and we need to identify in a situation, in a scenario that is going to be a high threat scenario, what am I going to do? What can I do? It's almost as if you have that skill set because risk and vulnerability and identifying that isn't difficult. And so the things you have to do is you identify what those hazards are, right? You decide who might be harmed by those, whether it's yourself, a staff member, or patients or family members might be harmed. You do this over tripping hazards or the slip, trips, and falls within inside of your organization, that kind of stuff. You can look at it from a security standpoint too. Evaluate the risk and decide some of the precautions that you put into place, record the findings, and then just implement them. Find ways to be able to do that, whether that is higher desks in certain locations, whether that is buzzers on doors, whether that is having doors secured at all times. There's different ways that you can mitigate the security risk by just putting common sense on the facilities that you're in. And as we go through the scenarios, we're going to talk through that too. And some of the things when it comes to workplace violence. As we talked about, your workplace is everyone within inside of your environment. Now, workplace violence oftentimes starts with just bullying and offensive language. Not necessarily elevated language, because we've known there's times where people try to get their point across through elevated speak. That elevated speak might not be violent in nature, but there's times when it does get that way. When the person is getting aggressive and you know the next thing is going to be something else that's going to hurt you, okay? That's when it leads to physical assault. And then, God forbid, anything like homicide. And then, Brenda?
Here I go. We have a series of techniques that you could use them, one sequentially, or you could use them as you need to in the encounter. One of the things that has always helped me is I go into each situation knowing what I want to accomplish. It depends on what the family is presenting, what the team is presenting, what your front desk staff is presenting. So it's always knowing what you want to get out of the encounter. That will help you be nimble and flexible and move with what the family is saying to you about what their concern is. But if you come into the engagement or the encounter with the family with a set mindset that you're not going to change your plan, that they're not going to get where you've lost that family right away. Your body language is going to say that, your tone is going to say that, and you may lose a client, a patient family. If that is your goal, you try that scenario and it will happen eventually. But I think it's important, if you hear the scenario, you figure out that I want to reach a resolution of some sort where we both win. How can we both win in this? And you know your practices, you know the size of your, what the workload is that day. But I think it's important to know, I always go in with, I am going to de-escalate this. I am going to look for any way to help the family win, and help the situation be de-escalated, and we win because the family's that way. So there are 10 techniques. Be empathetic and non-judgmental. So what I'm talking about is not being judgmental, it's thinking that these are the goals, this is what I want to accomplish. Respect personal space. Don't get too close. Don't get up in anyone's face. That's a dangerous place. You will get hurt. Yeah, like stay over there. It makes people, families nervous, so be respectful of their personal space. It's also important to, when you introduce an idea or a concept of what you want to do, allow people to have time. Don't rush them in their decision making. I'm not saying tomorrow, but give them a few minutes to think about it, and then check that you are their understanding, validate, clarify what you may have suggested. Use non-threatening and non-verbals. We have to watch our body language. We can't be sucking our teeth. We can't be rolling. We can't do any of that. Rolling our eyes and giving the family the impression that they are a nuisance to you. They're your most valuable customer, and that patient is even more valuable to all of us. You do have to set limits. As a social worker, I kind of let people, and then I sort of bring it in. But you're negotiating at the same time, but you're bringing in. So this is not without limits. It's not giving things away unnecessarily. But it's important to acknowledge people's feelings, because their feelings behind what's happening in this situation. And it's important, don't go down that rabbit hole of some of the challenging questions. People like to deflect. They also like to get you off track. So you don't know what's happening at some point, but be very focused. That mindset about what you want to accomplish in the encounter should be at the top. And avoid overreacting. I have a reputation of being very calm. That's practice, that's not. I bring it down. I set myself in a mindset. When I do, I set it even with staff, I'm not gonna overreact. Even when your buttons are pushed. This is the same scenario. Be calm. People will read your body language in a different way. And this goes along with the setting limits. Choose what you insist upon very wisely. So it's a thought process. And you allow the families to reflect. And this is important because you want them to process. A part of when people are at high emotion, they're not thinking, none of us think there. And logic can't get in. We can't even sometimes pull all our thoughts together. So it's allow people to come to a level where they can actually engage in a more productive conversation. And it's just such an important thing, is that you don't rush it, yet you are purposefully moving along a path. This takes practice in doing. I think one of the things I would suggest in smaller practices, if you got folks who are great at engagement, that may be your first person that you're helping them and practicing having difficult patients come through, or difficult families, I should say, come through, is what I'm going to do, how am I going to do it. Paul's going to talk, he's already talked about your physical space, how to be safe in a smaller practice, unlike Children's Hospital. We do have security guards on the premises. We do have a police officer on the premise, so we have resources that you may not have. So it's important to find your go-to de-escalating team within your own. And I want to say, as physicians, you actually control the outcome more than you think. A physician intervening can take the absolute hostility out of that encounter, because you are respected. They come to you for a reason, but sometimes they feel that front desk is not allowing them to get to the physician, or the physician may not even know, because they were seeing patients. So it's important to know that at times that you may be the one who really resolved the issue with your with that family that's really upset. Okay.
Okay, so and before we get into our scenarios, we're just going to give some resources. So as we talked about, the design of your physical environment is always a resource. Any of the resources you can dedicate to enhance those, doors, lights, mirrors, phones, desks, intercom systems, cameras, badge readers, all these other things that are very much intensive in putting into place are all things you can enhance your physical environment with. Staffing, of course, any type of security staff, but also admin staff can be utilized for that capacity in the screening of people in and out of a facility also. And then local emergency response. We need to understand what our 911 goes to. If you have panic alarms in your offices, you need to know where they enunciate at and how all of that is done. It's very important to know what those response times for any type of emergency situation that you can have. And then, as we talked about, the duress alarms or alarms for your locations and how they terminate. And then training, de-escalation techniques for training. If we're not doing it, it's one of those things that just needs to be one of those things we talk about. Find out who that person is, as Brenda had talked about. Get that training in place and make sure that we enforce that positive behavior. And then there's Joint Commission standards. Have the link here, so when the slides get given out to everyone, you'll be able to see what those Joint Commission standards that we have for any type of workplace violence inside of our healthcare processes. Okay. Now we're getting into the fun part. So just real quick, Brenda's going to do the first scenario. The scenarios were put together. Brenda and I put them together based on what we thought would be best for working with your practices and understanding that these events could potentially happen. The one thing that we want to do is when we question and walk through things, we want to always consider the physical environment that this is taking place, the threat impact. So what is impact of this threat going to do to your organization? Any de-escalation techniques we would want to use, and then any type of follow-up actions that we would do with that family, right? They're potentially coming back. So what is the next step for them, and where do you go from there? The other thing is every one of these scenarios, even though some of them are pretty strange, these have all happened to Brenda and I, right? So know that we've dealt with every one of these already. So Brenda, you're on.
Oh yeah, this is one of my favorite ones. The parent arrives late, an hour late, and you all have very tight schedules. She appears frustrated and is not happy to hear that they can reschedule or they can wait for an opening in the schedule. The parent made verbal threats towards the staff and another family in the waiting room. The threat was, "I will stomp you out."
You didn't say that tough enough, Brenda.
I don't know.
I will stomp you out. Okay.
Well, I don't think you're any tougher than I am. Yeah, well, sometimes families come in very intimidating, and the way they're dressed, and they sound that way. I don't know if I can say I will stomp you out any harder. But they say that they kind of, if you don't have a glass enclosure, they're pretty close to you. and that's pretty threatening. So
What are our thoughts?
what are your thoughts? You know your environment, 15 minutes, we're gonna run through these very well, fast.
If you could raise your hand, we're gonna bring the microphone in, and some of those things, again, to think about, physical environment, the threat impact that they have, and then what de-escalation would you use here? Should this person stay within inside of the practice? Is it scaring the other people that are in the waiting room? What are some of your thoughts? Does this person leave and get told to come back a different day?
Yeah, go ahead and stand up. So this happens sometimes, and so this last week or so I actually came out of the room, and it was a mom, she was crying, and I said, look, listen, the baby, this is what we can do. We can give you your shots today, so mom was happy about that, and then you'll come back next week and we can give you a well visit, so we can follow the development and all that stuff. And she was happy with that.
You found a way to compromise, that win-win, there was a win-win, that is important.
And then there's follow-up. So they're still gonna be able to get the care, but there's follow-up and you'll be able to figure it out where it's safe now. Okay? It was de-escalated.
Good job, good job. I don't know what your role is. What was your role? What's your role in your practice?
I'm just a pediatrician.
You're more than just a pediatrician. Much more than that. Bravo, bravo, great job.
Okay. Some other thoughts. If you're in a situation where maybe your environment has it where your staff is very close to an individual who's saying that and that threat has been made, what are some considerations for the future? Do you look at your environment and you maybe want to change this, or maybe is there certain times when this person should be coming versus high times when the waiting room is full with a lot of people, maybe appointments are set at different times, other things? Can these things be done? Is there anything like that? Everybody's shy, aren't they? It's a big group. It's after lunch. Oh, okay, we have one that's not shy up front.
I have the advantage of being in a small practice. So usually I can kind of talk to people in a more personal way. Like, girl, you know better than to act like that. Just saying.
So that's
And then they laugh like y'all did. And you're just bringing it down. Come on, let's bring this down. Let's bring this down, and let's see what we can do to fix this.
That is beautiful. That's exactly what you want to do. You want to make sure that everybody understands that this is going to get lowered and that you're in control, right? You took control by downplaying it, right? And then that situation ended up getting resolved.
Right.
So, very good.
And you demonstrated that you heard her or him. And that's is important to all of us, to be heard. Without that, we all will go out of control. Yeah, because that's just who we are as human beings.
Okay, we're going to go to the next
Yes.
one, since we do have limited time. We could really be here for like 3-4 hours if you don't like, but we'll have to start paying per diem. Okay, so in this situation, we have primary care clinic, Washington, D.C. Security presence, you have one security member that is there. Parents come out of their appointment and are arguing loud, profane statements about care decisions. It is not provider related. All right, so this is the two parents arguing, having a domestic event. Parent 1 strikes parent 2 with a closed fist to the face 2 times. Parent 2 is holding a 2-year-old child and attempts to fight back. What are some of our thoughts? So the thoughts that initially come to my mind is that child isn't safe, right? If I'm in a small primary care clinic or location, I'm thinking also the space that they're having their domestic event in is going to spill over and potentially hurt staff or other children or other visitors, right? So what are some of the things that need to be done in this situation?
I have a question before we even get there.
Yeah.
How many folks experience domestic events in their practice?
How many folks experience domestic events in their practices? Yeah, okay,
Okay.
yeah.
So we've got some experts here. Like to hear what happened.
Yeah, I would just say the first thing that when you're talking about actual violence like that, you're trying to get your staff to call 911 and get the police there immediately. I mean,
First
in
one,
this
call
case, you at
911,
least
very
have
good.
some security, but, you know, the first thing is more of the danger to your staff, to everyone around them. I mean, you definitely want to protect this second parent, but the truth is, like, the first step is that this person is actually physically violent, and it's already happened.
Correct.
So,
They committed a crime.
yeah, and so police is really your first step, and protecting yourself from being the next person that they hit.
Yep.
So I think maintaining your distance is going to be one of the biggest things to talk about, and trying to keep them in a space where you get everyone else out of the way right away.
Very good, very good. So the security professional, what their responsibility is to make sure that that domestic event does not spill over. The rest, another member of the staff, if they can contact, either there's a panic alarm that goes straight to 911, or there could be a call to 911 to get that person there. Any type of assault like that, you would want to make sure that you're contacting law enforcement. Okay? Any other things in here? How about the 2-year-old child? I've actually seen situations where the domestic event is happening and you ask for their child. We will take care of this, right? And then taken from them. And then the event can play its way out, but you want it to stop. But the most important person that is engaged in this event is that 2-year-old, right? Because they could potentially be dropped, or they could be struck themselves, all right? Which would be catastrophic.
So in those cases, there are a couple other things. If the child, I'm sorry, I always get away from the mic. If the child is injured, or there's a potential for both parents because of their behavior, the police take them away, what do? You're going to have to call the local CPS agency. They say that now you have a child who's unattended. It will prolong the time that the office is open, but it is about keeping that child safe and making sure that the environment that they go back to is safe.
That's a tough call.
That's a tough call. We do that frequently, unfortunately.
Any other thoughts? Okay. Brenda, you're up.
Up again. Oh, this is a community practice in Prince George's County. The staff person involved is a receptionist. Front desk staff, they get it, all kinds. Your front desk staff received a call from a parent inquiring about the availability of completed health forms. This is not the season of health forms right now, but it's coming again. The parent said to the front desk staff, "Did you get my messages?" Per the parent, they dropped forms off 3 weeks ago. The parent has tried to get a message with the doctor's office on several occasions, and has left messages. The last message on the voicemail concerned staff because of the level of anger in the message, and the parent stated, "I'm coming over there to get my paperwork, and it better be ready." Have you heard that before?
How come Brenda always gets the speaking part?
I mean, it's like, it's my little drama. I think I'm a frustrated actress. So tell us a little bit about what, this is common, and families, I'm coming over there, I'm gonna do something to you. How do you prepare for that? You know someone's coming.
That's potentially violent.
You don't know when, so you can't close the door for everybody. But tell me how would you prepare? Okay.
Honestly, I'd just say the first thing is to apologize for the delay in getting their paperwork to them, and that usually de-escalates the situation. And then giving them their paperwork, they usually will leave happy, even though they've been upset on the phone.
Yeah. Identifying regret or sympathy for what has been done.
Yeah.
Okay. We had a comment in the corner also. Oh, yours was similar? Same thing? Okay. Any other comment?
This gentleman right here in the front, middle aisle, middle way.
What would you do with your team as you prepare to?
Thank you. So if I have a message from a parent says, "I'm coming over, my stuff better be ready." First thing I want to do is look at, see if we actually have anything on file from them. If we have it, we need to expedite because it's on us for being late. If we don't have anything, then we make sure somebody in a position of authority is there when they come in to apologize and say, we cannot find anything, give us the form, we'll process it right away. But de-escalate in that sense to make sure they're getting satisfaction. But I think the first thing you want to do is make sure that you do or do not have that on file.
Yeah, so you go through the thing that they need, then you walk through that de-escalation process of what you would do if you don't have it. And if you do have it prepared, ready to go, so there's no fuss, right? Yeah, it's a very good plan. Anything else?
Really good.
This, I would be pretty annoyed too if I had a form at the doctor's office and I kept leaving message and no one had it. This seems like a totally legit reason to be angry if you're expected to have the form in 5 days or 3 days or whatever, and you don't. It doesn't seem like this is a, this is not, the anger doesn't seem out of place to the event. And if we really don't have the form, they're very right to be angry. I would also waive the fee when we did give them the form because we messed up. Money always.
Exactly, and having things prepared, having the team ready to know that this is this person coming. If they say their name, that's this person that's coming. Make sure that everyone on the team is informed of what we're going to do, that kind of thing. And that way it de-escalates. Because if they get there and then the front desk person now comes across as not knowing or has an ignorance to the event itself, we have to make sure that that doesn't, again, give us another hit where it escalates that parent again.
Yeah, I think it's important that you mentioned being prepared. So if you can't get the family to calm down, what's the next thing? You need to have your backup plan for involving security or the police. So someone can be designated to watch to see how this encounter goes if it doesn't go well. We've seen things not go well, so you need to be prepared. And just thinking of it, it doesn't mean that the person is a bad person. It means that they're at a state they're not really able to be rational.
And then,
Just a question. This is the third scenario, and everybody has talked about physical environment, threat impact, de-escalation. What about the follow-up actions on the family side for this? Because we're dealing with the impact, but then what are the ramifications for the families in these scenarios?
So the one that I see in this scenario is this is one of those ones that's really an impact for follow-up actions for our office, right? So we would have to make sure, well, like, how did this happen? And how did we let this parent keep this parent on an island where they were waiting or they weren't prepared? Were they not following up themselves? Did we not do what we needed to do? So those would be the follow-up actions here. I think the domestic violence event, that's a difficult one. That's a difficult one. And so with that, there has to be some care provider conversations with that parent, those parents themselves. If there's one of the parents can maintain that ability to be able to bring the children to the child to the clinic or to the location, I think that's best. It's almost like you don't want them coming at the same time if you can't. Conversations on how does that child get care. If you run into that physical violence ones, you have to seriously look at what would the situation be where future care is potentially compromised. So, and Brenda, do you have any thoughts on that?
I think also if child protection is involved, you're going to need to be, be in touch or know what the plan is for that particular child. It may be, as Paul stated, with one of the parents, but you should always establish expectations, and that's always the after action plan, the expectations that you need to follow and what the family needs to follow. So you do have to set limits.
Yeah, the one thing that we do with the family is we set a plan, and we also have a collaborative agreement. It's an agreement that we would put together with the family on and expectations of behavior. And then we also talk about what we're going to provide and then what they are potentially going to provide also. So this is expectations of the care we're going to give, but then this is the way that we expect you to behave while we're providing that care. So we do that inside of our own hospitals. It's a collaborative agreement.
Paul,
Yes.
if I may,
I'm hearing.
right here.
Oh, there.
I was going to speak about something which you brought up is looking at why something went wrong internally. I'm a firm believer that when we fail at something, it's not a person's fault, it's the failure in the process. So if something like this happens, we do review where the process fell apart. Is it training issue? Is it education? Is it not enough staff, not enough time? And we try to address it from a process perspective, make sure that the process is in place. So yeah, you do want to look at inside and see why something like this happened.
That's always my first step with anything, especially if I am ever in a situation where I have to admit we were wrong. Well, it's a process problem. It's maybe a training problem. It's maybe you weren't prepared for the situation you were put into, and it happens. It happens. It happens to the best of us. We could all be great, but we don't all do it every day. So.
I just had an additional comment, which was not really about the Child Protective Service, but the sort of belligerent parent. I think that you want to de-escalate when they're there, and that's all well and good, but I think you have to follow up with that family because they need to know that they can't actually behave that way or they will be discharged from the practice, because we have a big practice and we have so many people that are really vulnerable at the front desk. Some of them are new, some of them are young, some of them, and they just can't be abused. And I think that that happens even more in times of COVID. I remember back in H1N1, people are screaming at our staff because they're so scared. We understand that they're scared, but they can't use certain language and they can't. So I think that there has to be that follow-up. You're not going to get that while they're in your face. Like, you have to do that afterwards. We usually write a letter. I always say before we discharge a family, you really want to talk to the provider to say, do you know about mental health in that patient? Maybe the father's bipolar, maybe the mother, and so that somebody needs to take care of the kid, but then you could do that collaborative agreement like you said, but you have to follow up on their behavior.
Follow up and documentation. It's making sure, in agreements, they're part of the care to this child, right? So what we have to do is we have to work out what we're going to do and what they're going to do. And it's an agreement. And then you refer back, you're not abiding by your agreement. So they can call you on it and you can call them on it. And so again, I don't know how many folks are, I think your process is spot on, but if we're not doing that already, we need to be documenting and making sure that happens, okay? And then let's see if we can get into, this is the ski mask one. Is there one more?
Yeah.
Okay, so who wants the ski mask one? Or I think we have 5 minutes, right? Okay, so 5 minutes. Okay, there's a ski mask one and okay, I'll do the ski mask one real fast. I'll give you the answers to it. Okay. How do I go back? Okay, so in this situation, we had a parent who came into one of our locations and was wearing a ski mask and sunglasses, okay? And was sitting in the waiting room, was scaring other patients. What we ended up doing is as Brenda had talked about, that high respect level. So our security professional asked the person to come back into one of the areas after the visitors had also said that they had worried about what this person was doing or why they were wearing a ski mask and sunglasses inside of the waiting room. The physician then brought him back into the room. The physician said, I will go talk to them. He went and talked to them, and the man ended up taking his ski mask off. He felt more comfortable. He didn't like being around cameras. He didn't like being around in the COVID environment. He felt unsafe not having some sort of mask over his face, which was a ski mask. We provided him with an additional mask that he could wear that would make everybody feel safer, and he went back to waiting in the waiting room, all right? You have to take into account some other people's fears of their environment, and then also the fears that they may have of the equipment that you have inside of your facility. Everybody has their own unique situation, and we need to also work with that too. And so this parent ended up being happy with it, didn't have any type of confrontation with our leadership, and they ended up settling this thing pretty quick.
So two things that happened, that father was separated from the general population, if that is possible, and put in a room, and the physician took the lead to find out what was going on. And this is what we found out. Yeah. He wasn't a dangerous person at all. But sometimes everyone was reacting to the ski mask and the glasses.
He was just scared himself.
Yeah.
And then the final, and I'm going to read this one. This happened, a homeless individual it's affected our receptionist. A homeless individual was loitering outside the clinic for 5 minutes, witnessed by the receptionist. The individual followed a family into the clinic. They were buzzed in. The individual appears to be uneasy and pacing in the waiting room, and after 5 minutes asked for the bathroom, which is in one of the back areas. The receptionist asks why the individual is there. The individual screams profanity at the receptionist and punches the objects off the receptionist's desk counter and rushes out of the clinic. So this is one area that we also problem solve. They broke equipment, but this is also one area of physical environment. So they did get buzzed, but a person tailgated them in. Right? So that's often a worry that we also have to make sure that it doesn't happen. So, but they were allowed to, again, wait in the visitor area when it was clear that they were not supposed to be there and they weren't with that parent. All right. So this is one of those areas that, what would you do in this situation? Would this be a 911 call? Yeah, probably. And then this individual didn't know what he was doing. He was confused to where he was. Once his confusion became too overpowering for him, he ended up exploding and reacting and threw all the things off of the desk onto it. There's physical environments that you can have changed also. If you can look at desks and other things that are higher, elevated, that maybe have guards on them, that can help receptionists also. Always having buzzers on doors can help if you have a large homeless population or a group of people that you fear might be coming into your facility that aren't welcome. And then having, one of the areas that we have noticed with our facility is this facility didn't have a secure door to the back. All right, so if this individual decided that they wanted to get more violent, they would have had the ability to go all the way to the back and affect every person within inside of that clinic location. All right, so having that barrier between the waiting room and the back area is very important, and it should be controlled also. So those are just some physical things. Any other comments about this scenario? Sorry, we're rushing to the last two. I know everybody's been having fun with it.
Yes.
Okay.
With the multiple incidences of police overreacting with people with mental disabilities, I would be concerned about calling 911 on a patient or on a person, homeless person that is behaving so erratically. So what is the alternative? Do we call social services? Do we call something else?
In most jurisdictions, there's a crisis, mobile crisis, or some crisis line that you can also call. But you don't know what this person is capable of. So you could do that, but you can also call the police as backup. One of the things I know about mobile crisis, police and them, they communicate with each other. So if there's an incident, they'll know about it because the mobile crisis team also needs backup. They don't know exactly what they're walking into as well. Every jurisdiction has one. So that's a good number to have for your team, to know what those crisis numbers are and to get someone in there fairly quickly. But sometimes they'll deploy the police first. The police will wait for that team to come. But the police's job is to secure the perimeter. This particular person ran out. So there's a concern about where is he going? Will he come back? Can he hurt himself somewhere else? So you would report this to the police, give a description, that's important, to give a description so that he can be protected and taken to a better environment.
Anything additional? Okay, I think our time is up, and but we'll go to our final slide, which is any questions. We will be available during I think there's a break right after this. Yeah. And if you have any questions or you need advice or you want to talk about some of your locations and you want to see what Brenda and I can help you with, we'll be available right after this.
Okay. Thank you. You've been a great group. Thank you.
So Brenda and Paul will be available during the break to answer questions. Couple different things, and before you leave, just validate this one thing. So it's easy sometimes to think, oh, these are things that just happen in those practices, not my practice. And maybe some of this is disproportionately represented in communities that are under economic stress or other sorts of things. But in this day, all you need to do is watch the evening news to see that violent outbursts know no boundaries. They don't know neighborhood boundaries. They don't know socioeconomic boundaries. They don't own, home income boundaries. They happen all over the place, maybe at different levels. So one of the take-homes is to go back to your practices, and at one of your practice meetings, think about what would we do if? And it just helps you begin to say, do we even have the numbers to call? Do we know what numbers to call? Who's the resources in my county for my practice? Because we're spread out all over the map. But that's important inventorying and important pre-work, because that will generate other conversations and help you move upstream to begin to anticipate some of these and de-escalate them before it gets to a really bad place. So I want to thank Brenda and Paul for introducing and providing some case studies and whatever, but this is a presentation where you have real homework. And I'm begging, I'm asking each of you to go back and really think about it and think about what it means for your practices, because if we can better recognize and anticipate, we can sometimes head things off before something really sad happens. So I appreciate everyone's engagement and want to thank Brenda and Paul, and they'll be available for questions. We're going to take about a 10-minute break to do some table clearing. The exhibit hall's opening, and we'll open again. There's a second afternoon break, so there's opportunity to sort of get up and get around. We are starting in about 10 minutes with Paul Vanchiere, who's going to talk about understanding your practice value and planning for the future and other sorts of things. So we're going to regroup in 10 minutes. Thank you. Do you have, oh, this? That
Test,
green
1, 2,
thing.
test. You can
So
hear me
go-
okay? Okay.
But if you're over, you can advance the slide. Did they do some of the advanced slide work? No. All right, so you said green button. And then that's where that's at. Yeah. You can see it's a friendly print. All that will look at you. I've been swamped with emails and a bunch of other things, so I thought I saw something about you asking about dinner, and I told you to find me dinner. But I love at some point, we don't get to sort of connect and understand. I mean, you know what you're like. Yeah. This is Mark. Yeah, you don't see me up here. I will keep this is all about elevating this community. We do that in the summer when we bring specials. I'll be committee line. All right, folks, up. Here we go. We're going to encourage folks to regather so we can start our afternoon program, which is just as good as the morning program. So there's going to be some drift in from the other room. Can you just go back to the title slide for 1 second? Oh, okay, go there. All good. Awesome. All right, all right, all right. So let's try to get folks at their seats so we can begin to sort of quiet down. And I think this is a relatively new topic for Business of Pediatrics. It's focused on looking at your practice and practice information in a different sort of way as it relates to your practice value and succession planning. And I would note that this is actually our 26th year of Business of Pediatrics. When we started this, the pediatrician champions in this room were Charlie Schulte and Tom Sullivan and Lillian Beard, Art Guarinello. These were the pediatricians of the last generation who really helped build the success of this particular generation. But at some point, they retired. They had to step back. There are these practice transitions about practice leaders who at some point are stepping back from being leaders, and then what happens to the practice, and is there a process for doing that? Which brings us to Paul Vanchiere, who's going to actually help sort of build out that concept and data and help us sort of understand what this all means. Did I get it right? Good.
Good afternoon, everybody. I hope everyone's doing well. It's funny he mentioned Dr. Schulte's name, and Dr. Schulte and my father were friends years ago. They used to do practice management things together. But my name's Paul Vanchiere, and I appreciate the opportunity to join y'all today. My current role is I'm the founder and principal consultant with the Pediatric Management Institute, and I am also the chief financial officer for Greenwood Pediatrics in the Denver area, as well as all pediatrics here in the DC area. With that, I'm going to be sharing with you information about succession planning. And this is based on my experience working with practices around the country, and I hope to share with you some things to think about as you think about what the succession plan looks like for your practice. Anyone who knows me knows I love to tell a good story, so here's your story time. Back in December of 1999, as we were getting ready for the Y2K bug and everything else going on then, my father had a practice in Southwest Louisiana, and he's the short, portly man in that picture. And the other gentleman is Dr. Calhoun. And Dr. Calhoun in December of 1999 was planning to retire in January of 2000. It had been long anticipated. They had a plan, and they knew what they were going to do. They knew what the buyout amount was going to be. They knew how they were going to handle the succession of managerial responsibilities. And so everything was trucking along until January 24th of 2000. Less than a week before Dr. Calhoun was set to retire, my father had a stroke and passed away. And my father was the managing partner for the practice. And for a practice that was, at the time, the largest independent pediatric practice in Louisiana, it was still going to be very difficult to fill the gap of administrative responsibilities as well as the financial consideration. But what I'm here today to share with you is that with good planning, you could avoid some significant problems in guaranteeing the future success of the continuation of the medical home. And so a lot of this is inspired by events that took place 23 years ago, but still are applicable to this very day. We're going to kind of dance around a few things. This agenda is not necessarily the order in which things will be done, but we're going to talk about why practice valuations are important. We're going to, can you turn this mic off? Okay, here we go. So we're going to look at evaluation. We're going to review a couple of them. We're going to walk through an example. And all along the way, we're going to talk about some things that you need to be thinking about. But your entire practice and everything you do should be dictated by the culture of your practice. The practice culture should be setting the pace on everything that needs to be done within the practice, and all the decisions that are made. Those decisions may include how you structure your shareholder or partnership agreement, and as well as your practice valuation down to how you are compensated. Yeah, I'll just use this one. Yeah. So we can have them turn it back on. Okay. Can everyone hear me okay? Yeah, good. I tend to walk when I talk, and it's just out of nervousness. So I'll have to find a way to channel my nervousness another way. So, but your practice culture should be what dictates all the decisions that you make within your practice. On how you treat your employees, your policies, what you're doing, your partnership agreements, everything should be driven by the culture within your practice, and all the way down to the compensation. Now, sometimes, and we could do a whole presentation and spend another 3 hours talking about how you should be crafting compensation model. But for right now, for the purposes of today, we want to throw this out as a suggestion that owners and partners in the practice consider divvying up how you pay yourselves as owners or partners within a practice. You know, it's not uncommon where we'll have a partner that they get their base salary, and then different parts of the business fuel in and provide additional income to those partners and owners. And some of those additional margins come from vaccines, what you're paying for it versus what you get. You can look at productivity components for even your partners, as well as your provider margin from your employee providers. So these are different elements that go into structuring what we see at the bottom, which is the compensation of base pay and how you're going to split the pot and what's left over. These are the types of things that are going to feed into the practice valuation. And if you segment it and you think about it this way, it does make some things a lot easier on the financial side. Taking a step back, looking at the future of pediatric practices, I believe that the future is very bright. But the reality is that there are headwinds. Going from right to left, you know, the supply of newly minted pediatricians is dwindling. We can also look at the fact that in other markets, not necessarily here, but in other markets, we see very strong competition from the hospitals to employ the dwindling supply of newly minted pediatricians. Add to that the complexities of declining margin. How many of you have seen an increase in your labor cost in the last 2 years? And so what happens is payments remain flat and your costs are increasing, what's shrinking? The margin. And so there are headwinds that we need to acknowledge, but they are manageable. And they must be managed in order for the pediatric independent practices to remain viable. With regard to succession planning, with regard to think about the future of your practice, we need to be thinking and start to drift into the area of who is going to buy your practice in the future? Who is going to assume ownership within your practice in the future? And in order to properly assess this, we have to accept a couple of realities. Number one is that there are limited buyers. You know, if we were to look at a pediatric practice, you know, not anyone can buy a pediatric practice. Anyone can buy a Jiffy Lube or McDonald's if they have the capital, but not anyone on the street can buy a pediatric practice. So now we have a very limited quantity of buyers that are technically for the most part, eligible to purchase the practice. There's usually limited interest. How many of you are facing a situation where employed pediatricians within your practice have not expressed a strong desire to be an owner in a practice? That's pretty common. So we have a limited number of buyers, we have a dwindling interest, and at the same time, there are some other things that affect valuation that we'll talk about in a few minutes. But this is a very tough marketplace for independent pediatric practices to remain independent, but it is doable with proper planning, following good cultural values within your practice. It can be done. The reason we need succession planning is to think about the future. You need to be thinking about the reality that I'd hate to be the bearer of bad news, but in 100 years, none of us are going to be around. At some point, everyone is going to divest their interest within their practice. Sometimes it's accelerated because of disability. Sometimes a partner unexpectedly passes away. Sometimes there may be divorce situation where it forces a monetary value to be assigned to that asset. For whatever reason, you need to be thinking about the future. So if at some point we need to figure out the value of the practice, how do we do it? There are three traditional methods that are used within the industry. The first is the income approach, which looks at the cash that's flowing through the practice or the profits or the earnings of the practice, and they examine that in a unique way to determine a value. There's an asset approach where they simply look at the balance sheet and say, look, this is the value of the accounts receivable, cash on hand, and other assets, known as the asset approach, from which they deduct your liabilities and they come up with a number. And then the last is the market approach. The market approach is very similar. The best example I can think of is when you go to sell a house. I have a house that's 2,000 square feet. The average price per square foot recently sold down the street, and that's how we extrapolate a market approach. Unfortunately, the market approach does not work in a pediatric practice. You can have two practices of the same size, one block from each other, but the numbers are so different, the market approach is not really applicable. When we look at the asset approach, it's not really fair because it's not taking into account what we hope to realize the true value of the business. And so that's why many valuations within pediatric practices that we've done, and we do about 3 or 5 a month now, and it's really heavily weighted toward the income approach. Now, these are some more details that we could go into, but for the most part, these are the guiding major categories and how general businesses are categorized. And what I'm going to share with you in a few minutes is how Pediatric Management Institute approaches practice valuation and kind of blends some of these different elements together to help determine a value for a pediatric practice. So before we get to that, we need to understand what is the purpose, what is the objective behind a valuation. First, we want to establish a fair and mutually agreed upon price. We want to establish a formula ahead of time. That way, before the need arises, we know what the expected value is going to be. If you don't know the exact number, you at least know the formula. Because the worst thing that could happen is you have the unexpected departure of a physician and having to come up with a value. In general, people who are in business together and pediatricians who own their own practice are a lot more amicable to determine what's fair and well in advance of the need. And it's just something to think about. So that's why we encourage people to develop a formula that I'll share with you and update those numbers on a regular basis. But at the end of the day, we have to go back to Economics 101 or Economics 101 is what should the purchase price be? It's what the seller's willing to accept and the buyer's willing to pay. And so what we're encouraging practices to do is, before you get into that emotional situation of a recent passing or someone leaving unexpectedly, do what you can to plan ahead so that you know exactly what's going on before the need arises. So this is where we're going to kind of branch into two different areas. Number one is what we call internal buyout, and the second is external buyout. So for the frame of context, the internal option is usually in a situation where someone within the practice is going to purchase a position of ownership within the practice. External means a third party, such as a hospital or an organization who's not normally associated with your practice. That sound reasonable, just for frame of reference? So within the internal valuation, there are a couple ways to do it. And we can think about that scenario of an associate or someone who's been in your practice for several years, you're grooming them for management responsibility, and eventually they want to become a partner, to have a seat at the table and share in the profit. That's the internal buyout option that we're going to look at. One of the external buyout options is selling to a hospital. It's not very heavy in this area, I can think of a dozen markets around the country where the hospitals are actively soliciting to purchase practices. And I'm not going to dwell too much time because this is a regional thing. It's not as heavy in this area. But I will say that in these situations, because you may have colleagues in other parts of the country that you could share information with, there are two main things that are limiting hospitals when they come and purchase a practice. First is the concept of inurement. Inurement, it applies to tax-exempt organization, and basically they want to make sure that the individual that's receiving funds in exchange for the purchase of their practice is not being enriched in an unfair way. That's contrary to the not-for-profit intent. The second is fraud and abuse. There are limitations called the Stark laws, in which hospitals are limited in what they can pay for a practice simply because it can't be seen as an inducement for referral. So again, we're not going to dwell too much, but those are really the things that are governing hospital acquisition. And normally the deals are structured in the following manner. They will purchase a practice for the asset value. There was that middle one in the column in the slide that I showed earlier. It's asset driven, so they look at your asset to track your liability. And then they will provide a compensation package to the remaining position. And then if you own your building, they'll work out a lease arrangement. That's normally how these deals work. But again, it's not very popular here in this area. So I could probably talk for 3 hours on this. But just to give you a broad overview of what those external options look like. This is publicly available information. Some of the hospitals are employing what's called a subsidiary model, where they partner with a practice and the practice becomes a subsidiary in its own formation. And again, this is probably for another day, but just interesting information to have and how the hospitals are structuring those. Within a given area, you may see a large competitor. A large competitor you're interested in partnering with or being acquired by. Really, in order for this to work, you have to think about the person buying the practice or partnering with the practice having access to better paying contracts. I don't see huge market disparities in this particular area, but it is something to think about. There could be some economies of scale. There could be some other things that are at play that makes it sensible for a smaller practice to join a larger practice. And so one of the things that they look to do is called strength in numbers. Come together, receive some economies of scale. Operationally, how can we reduce some cost and feed the bottom line? Strength in numbers is really the most important thing. Strength in numbers is what gives you the ability to negotiate favorable contracts. And so when you're thinking about your future plan for the practice, partnering with another practice could make a lot of sense because there's strength in numbers when it comes time to negotiating contracts. There's another player that's emerged in the last couple of years. Well, not a couple of years, in the last 18 months. There has been a very strong interest by private equity firms. I used to tell, I have a couple of buddies who work with private equity firms, and I'm like, y'all are scraping the bottom of the barrel if you think there's a lot of money in pediatrics. Because there's really not a whole lot of leftover money. It's not like orthopedics where you can have a surgical center, or a dermatologist where they have their own dermatopathologist lab and everything else. The only thing that pediatricians have going for them is the ability to see more than 20 patients a day, doing vaccines. They're just not the option. But there is strong interest in private equity, and they popped up in the last 18 months, and there is very strong interest in the Virginia market in particular. And so that's why I want to take a couple minutes to educate you on what opportunities may come your way. The private equity firms are looking to deploy a dual strategy. One is a horizontal strategy where they acquire practices, bring them together, get some economies of scale, collectively negotiate contracts, and offer that opportunity. There's also a vertical strategy. Of the 9 private equity firms that I've spoken with in the last 12 months, they all have one end game in sight: the Medicaid population. Over 50% of children in the United States are now covered by Medicaid. And believe it or not, there is a lot of money tied up in the opportunity to provide or be a part of providing care for children. And it's done usually at a state level. And so what the private equity firms are looking to do is partner with practices in a given state, develop a relationship, and provide what are called at-risk contracts to the state. We could go into a lot of detail on what their objectives are, but I merely share this with you to know what could be coming. And as part of that, when the private equity partners with a practice, they're going to look at what your earnings are. The lingo in finance is EBITDA, earnings before interest, taxes, depreciation, and amortization. And with this information, what they're going to do is they're going to take a number and they're going to assign it to a multiple. And that multiple could be 2, 3, 4, 5, sometimes as high as 6. And that's what they're looking to do: establish a value of your practice, and then they're going to offer you the opportunity: how much do you want up front, or how much do you want to defer in equity into the future? So these are some of the deals that I think you will find becoming more apparent within the region, and has already run its course in other markets around the country. And I share this with you so that you're prepared to at least have that conversation with them as the opportunity arrives. The last 2 things about private equity-backed firms is that there are a lot of things to be negotiated. And those negotiations depend on your ability to provide them information, and also to negotiate a good deal for yourself and the employed physician. And there are many things that are important that ultimately decide how much you receive up front versus how much you'll receive over time. And as I say always, you should always have a good accountant and a good lawyer who advises you on those types of deals, because they have the expertise to help and drive and guide the conversation. And the last comment I will say on the private equity is it's not for the faint of heart. The best way I can describe it, on the 8 transactions I've seen in the last 4 months, it's basically a colonoscopy without sedation. Okay? It is painful, and it hurts, because there's a lot going on, and when you go down this avenue, they are going to be looking under every nook and cranny, and they are hiring a lot of very expensive help to make sure that this is a safe investment for them. So it's not for the faint of heart, and I express that word of caution and know what you're getting into, and it can be very expensive. But with the right partner, it can be very fruitful, and that partner, not just an upfront payment, but providing resources for you to continue growing your practice. So with that out of the way, let's do a little reality check. The reality check as it relates to succession in general is that pediatrics is a very stable and resilient business. As a collective group, we got through the pandemic fairly well. Even if you were to back out the PPP loans and the ERC, how many of you got HRSA grants? You know, there was a lot of federal money that was coming in, and even without that, many of you would have been okay. But it was sure nice to get. But the business of pediatrics is very resilient because there will always be a need to take care of children. That's the one thing you have going for you. And the ability to, that revenue stream can be there at all times as long as you manage the practice really well. Every provider, full-time equivalent basis, as Chip mentioned earlier, should be around $500,000 to $700,000 per year in revenue generation. And the revenue stream that's generated does have value. And as we look at the valuation that we're going to go through, we'll see what that value looks like. How many of you have ever heard the phrase goodwill when it comes to valuing the pediatric practice? Okay. Anyone you ever see Men in Black? They hold up a pen and it zaps your memory. All right. Now, I'm going to hold up this clicker and look in here, and I'm going to zap that word out of your memory, okay? Because goodwill does not mean anything today in terms of determining the value of your practice. The goodwill is already received in your earnings year to year as a partner within your practice. So before we step into the formula, I want to go ahead and set this aside, that the benefit and the good that you have done for your practice, it's already reflected within the earnings that will be used in determining the value of your practice. So let's jump into a simple formula. I will say that what I'm about to walk through is on the PMI website, as well as the spreadsheet that I'm going to use, as well as a video that walks you through how to plug in your numbers. You don't have to pay someone to do this for you. My hope today is to kind of walk you through an example. But walking through the example is predicated on one key aspect in doing evaluation. How many of you here are a partner or owner within your practice? Okay. Every one of you who just raised your hand, you're wearing two hats. Your first hat is for the work of the pediatrician. So generally speaking, and these are rough numbers, the first $170,000 to $200,000 a year that you make is for your work as a pediatrician. After that is the benefit of owning the practice. So how do we segment those two hats in a way that makes maybe a little bit more sense? In this example, a partner in a practice made $210,000. Their work as a pediatrician was $165,000. And so what we do is we identify the benefit of owning the practice is approximately $45,000. This is the whole foundation of breaking out the benefit, how much you get paid for your work as a pediatrician versus dealing with HR responsibilities, worrying about making payroll and everything else. So it just makes general sense to everybody. And if so, we can then step into a scenario that we'll walk through over the next few minutes. Dr. Smith is a 65-year-old pediatrician. He wants to retire in 2 years. Dr. Johnson's a 45-year-old whippersnapper who's seeing a lot of patients, has a good rapport with the patients, and plans to be a good fit. They're a full-time nurse practitioner and a part-time nurse practitioner. So that's the scenario. This is the formula. Anyone who I've ever worked with, and there are a lot of familiar faces in this room, know that I like to put the formula. When I was in high school, I had an algebra teacher. She was a nun. And Sister Monica, or Sister Sledge, as my father called her, she always said, show your math, show the formula, show how you did it. And that resonated with me. And so that's what we do on all of our spreadsheets. And so you can go down this sheet and see exactly where did these numbers come from. We break it up into two parts, Part A and Part B. Part A is looking at the earnings portion. Remember that income approach that we talked about earlier? And then Part B looks at the assets minus liabilities, which is that asset component. So let's break it down into Part A. In Part A, this particular practice is generating $2.6 million in revenue. We have some expenses that included a provider salary and partner salary. But at the end of the day, at the bottom of the profit and loss statement, it says that we have $155,000 in profit. Out of those expenses of $2.6 million, we paid a salary to the owner of $160,000. We had a retirement match. And so if we add that to the ordinary income, the owner received about $322,000 in pay and earnings from the practice. Now, how does that compare to an employed provider within the practice who's making $160,000 plus a small retirement contribution? Here, when we compare those numbers, we're able to isolate and say, in a roundabout way, the benefit of owning the practice is worth about $173,000. Remember, this is all predicated on the formula of wearing two hats. For their work as a pediatrician, it's worth about $165,000 in this example. The benefit of owning the practice is approximately $173,000. From this, we then add in the assets such as cash on hand, equipment, your vaccine inventory, computer, chair, your accounts receivable, and then we back out what money you owe to determine the Part B value. And so in this scenario, we're very comfortable assigning a value between $500,000 and $600,000 as the value of this practice. Now, why is this helpful? This is helpful because now I can plan. If there are two partners in a practice and the total value is, say, $600,000, I know how much life insurance to take out on my partner in case of the untimely death. I also know that because all the spouses are signing the partnership agreement, in the event of a divorce, we know how much is going to be paid and not have to worry about a divorce lawyer coming in and counting every tongue blade in the office. So it allows you to plan for the good and the bad and the realistic scenarios that may happen, because now we can prepare for the future. With regard to the accounts receivable, that is usually a large asset within a practice. And so in this scenario, I propose that we're going to look and try to examine, if you notice right here, at the very last line, line number T6, Tom 6. I didn't hear anyone yell bingo, so I guess T6 is not a square on the bingo card. But T6, we estimated the value of the accounts receivable at $116,000. What we're trying to do is determine, as of a certain day, how much do we think we're going to collect? And that's what this exercise, I hope, providing for you, you'll find useful. So a couple years ago, I picked up the phone and I called a buddy. You may know him, his name's Chip Hart. And I said, Chip, look, we need to align ourselves a little bit when we're helping practices decide on how to determine the value of their accounts receivable. And we went back and forth and we kind of said, okay, we kind of like this approach and I want to share it with you today. The first step is look at your gross collection rate. So in this scenario, they brought in $2.2 million in charges. They had payment of 1.2. So the gross collection rate was around 55%. We're going to take that 55% and we're going to compare that to the existing accounts receivable. I will admit, and I think Chip would admit as well, because I've never heard of anyone to speak for him, we would say that this is a very conservative approach. As of today, the accounts receivable balance comes out to about $170,000. Of that 170, how much do we think we're going to be able to collect? And this is the exercise to at least try to get you in the ballpark on the conservative side. So we took that gross collection rate of 55% and we said, okay, insurance, $83,000, that's less than 30 days, 55.6%, that gross collection rate. And then every category, we reduce it by 5 percentage points. And here we have a method by which we can determine on the low side, out of $170,000, we should be able to collect $79,000. The reason I'm showing you the mechanics of this is so that good succession planning has a formula that you plug in numbers. And this is what we're proposing. Is whatever you do, you can change this up any way you want, but come up with that process so that when the need arises, you simply update those numbers. In fact, our recommendation is usually around every April, We run the value of every practice that we work with as of the end of the previous year. So let's walk through an example. In April of 2023, I received numbers from at least a dozen practices who ask us to update their numbers annually. And what we do is we say, this is the value as of December 31st, 2022. Any transactions occurring in 2023 is subject to this value. So every year, they're resetting the value, and the practice knows exactly how much any transaction will be valued at within the next 12 months. Anyone want to guess why April? It's when you file your tax return, and that's when your books are the cleanest. You've already got your depreciation, you've already got a lot of other things, and so that's why we encourage practices to look at it on once a year. You already agreed on the formula, let's just update the numbers. So that's really best practice for the practices. One of the biggest things is looking at the same set of numbers, what would the value of this practice that I described a few moments ago be to an internal buy-in versus an external third party? Summarizing the numbers, we can see that there's a significant difference. It's almost double. And that's why private equity has gained the interest in a lot of practices, because they offer an alternative to more accurately reflect the true business value of that practice. And so internal valuations are heavily discounted from the true value. And it's something to be said. It's something to keep in mind as you're moving through and thinking about your succession plan. The reality is that in order for independent pediatric practices to continue uninvolved with third parties, it does have to heavily discount the value of the practice. Because if you go to someone who's in their upper 30s and say, hey, the value of the practice is $700,000, we want you to be a 50% partner, are you ready to commit to $350,000 on top of that new house you just bought and still paying for it, on top of your medical school debt and everything else? It's not going to happen. So we do have to discount it in order for the independent pediatric practices to truly remain independent. And that's okay, because it is more art than science. So how do we get away from this, and how do we realign some of the expectations that may be occurring? And what we're going to do is kind of walk through a couple random thoughts that eventually, if I do this right, will tie back together to make that point. First of all, how much is too much to pay for a practice? At some point, you need to consider the alternative cost theory. Let's say, for example, that me and Chip, just because he's right there, and I have no shame in embarrassing him in any opportunity I get, I'll say, okay, Chip and I have a practice together. We're 50-50 owners. The value of the practice is $600,000 under an internal valuation approach. And we want to bring on a partner. For that partner to buy into a third, they would have to pay $200,000. Well, that new prospective partner may be thinking, you know what, for $200,000, can I open my own practice? I don't think you could at 200, but if your price is $1 million, it's a slam dunk. Why would I pay $500,000 into a practice? I could go open up my own practice. But that's another whole conversation. But the point is that there's a lot of price sensitivity, and we need to be mindful of the frame of mind of the people who are coming into the practice. One of the new things that's been emerging over the last couple of years are token payment. The token payment concept is Chip and I, again, we have a practice. We have a young person who's interested in becoming a partner, and we say to them, look, pay $50,000 and you have access to the profit. And when you leave, you get a % of your AR, and that's it. It's a very simple concept. It almost seems too simple. But for many practices that we've worked with, it seems to make a lot of sense. And the reason it makes sense is the reason they want to be a partner is because they want to share in the profits. Let's look at Microsoft stock. I buy some Microsoft stock today at a certain share price, and there are two ways to make money. I want to see an increase in the value of that stock, or there's another thing called distribution or earning. And what we contend under the token payment model is that you're receiving those distributions every single year. How many of you flush out the cash at the end of every year to minimize the tax liability at the corporate level, right? And since there are no retained earnings, there's no way to really drive the value of that stock price. And the same thing is happening in pediatric practices. So this is a new thing that's coming up, particularly in newly formed practices. It's simply a token payment to give you access to earnings from which, when you retire, you get a percentage of your AR. There are many things that affect the value, whether it's internal or external, and the formulas that we looked at is the guarantee of future volume. Because remember, those valuations that I walked you through were based on a certain set of numbers that we hope will repeat itself. We don't want to lose a major payer contract who's providing incentive that would totally undermine the future value. So we need the expectation of continued patient volume, payment rate, payer mix. If you have a practice that's predominantly on the very little Medicaid, and all of a sudden over time they're at 30, 40% Medicaid, that really changes the valuation because of the difference in payment rate. The local economy is of a particular interest. The DC area, as best I can tell, there's a lot of federal employees, and unless the federal government goes out of business, that you're going to have some money floating around the economy. The biggest contract is where I grew up in Lake Charles, Louisiana, which is driven by petrochemical plants. If you're a pediatrician there and one of the largest plants shuts down, that has a significant effect. So you need to be mindful of these things and what those things may be doing to influence the value of the practice. In either scenario, whether it's an internal or an external buy-in or buyout, you need to be ready to make some adjustments. COVID has made it very difficult to value some practices. So for those who receive PPP funds or employee retention credit, that's an influx of cash that may or may not be applicable in determining the value of the practice. The PPP loan was supposed to offset the reduction in revenue that you received a couple of years ago. Employee retention credit, the eligibility criteria was based on a reduction in revenue. And you might have to make some adjustments for that when you're looking at evaluation. But you need to be very upfront and think about it. So the scenario that I gave of Dr. Smith and the whippersnapper who's going to buy in, Dr. Smith is thinking about, what is the continued employment opportunity for her? Is she going to be a 4-day-a-weeker, or is she going to fill in? These are all negotiating items that also come into play when you're thinking about your succession planning. Who's going to be responsible for payroll, HR responsibility? And these are the types of things to be thinking about as you're thinking about the future of your practice and people who are coming in and leaving or becoming owners or divesting their interest. So if I have a practice with 6 providers in 2 locations, what is the correct number of partners? We have 4 choices. Is the answer 1, 2, 4, 6? It's a trick question. The answer to the question is what, Chip? As few as possible. Thank you. That is the correct answer. And we didn't coordinate it. I just know he just happened to be there, so I knew he'd answer the question. And he's right. The right number of partners is as few as possible to run the practice. There's a practice in, I'm just going to say Georgia, who called me one time and they said, look, we're really getting frustrated because we just can't seem to be making a whole lot of money, and we own our practice. And I'm like, oh, okay. And they were about the national average. And I was like, well, this doesn't sound right. I said, how many providers do you have? it was the same number. And the reality is that there needs to be a ratio. In order for independent pediatric practice owners to make money, you can only see so many patients a day. And there needs to be a ratio of the number of employee providers versus the number of partners or owners within a practice. Every employee provider should be able to spin off between $30,000 and $70,000 a year, probably lower on the scale. Depends on whether or not you include the vaccine, but there should be a margin. And the practices that do really well have 2, 3, sometimes 4 employee providers for every partner. And so as a partner, I can should be able to afford a salary, my own salary of $180,000 a year, but if you want to make $250,000, $300,000, $400,000, $500,000 a year, you need to have several employee positions or extenders generating profit that add to your own ability to generate income. Let's say, for example, you're thinking about someone buying into the practice. And the most common question I get is, okay, Hart and Vanchiere Pediatrics is going to bring on a new partner. She had agreed to pay us $200,000 over time. When does she get a seat at the table? She's going to pay us over 5 years. How many of you say that she gets a seat at the table at year 5 when she's fully paid in? How many of you say that she gets a seat at the table on day 1 when she commits to paying in? That is the answer. They've made a commitment to be a partner, you've established a price, and that's when they are going to become a partner. Believe it or not, there are some practices who say, look, as she makes those $50,000 a year payment or reduction in income, she is accumulating 25% per year in interest and earning. The best way I can explain this was by way of a trip to my local GMC pickup truck in July. I've been driving a minivan for way too long. I'm 50 years old. I think of all my friends from college, I'm the one with the youngest kids. And so they're all driving fancy cars and I'm still stuck in the minivan. Well, this July, Ellie turned 10. She turned 10 in May. I'm like, I don't need a minivan anymore. I'm getting me a pickup truck. So I went and bought me a GMC pickup truck. But what's interesting is when I bought the truck, I had to sign 2 documents. The first document was an agreement to purchase that pickup truck. It had a gobsmacking amount of money that I was obligated to pay because I didn't realize how expensive pickup trucks were. But there was this second document that said, aside from the price, I agreed to pay GMC Finance a certain amount of money. So 2 separate documents, one committing me to the purchase and the other one outlining the terms of my payment. The same thing can be said within a pediatric practice. As I commit, you get that young provider who's going to come in and commit to paying you over time, we can say, okay, in this example, buy a purchase price of $400,000. If you take longer to buy in or you have a lower upfront payment, it affects the interest rate. It's the same concept as when you're buying a car. But when I commit to buying that car, I have access to full rights and liability of ownership of that pickup truck. When an owner has signed a commitment to purchase a share within your practice, regardless of the time frame in which they buy in, they're committing to their prorated share of ownership within the practice. It's just going to take some time in order for them to be able to pay the remaining partner for that ownership within their practice. There are some things to also think about in your partnership agreement. Your partnership agreement, I'm not going to embarrass anyone by saying this, but I'd be willing to bet there's at least one of you in the room who may not have a partnership agreement. Because statistically shown, you'd be shocked the number of people who have no agreement between the partners or owners within a practice. And 99 times out of 100, it never ends well. So if you are one of those people who does not have a legally valid shareholder or partnership agreement, you need to reach your attorney and go ahead and draft one. And while you're doing it, or if you have one, these are some things to think about. I have no problem crafting the following elements within a partnership agreement. Number one, this is my favorite: failure to plan provision. If a partner does not give you at least 1 year's notice before retirement, their buyout is discounted 10, 20, 30, 40, 50%. Because the practice needs to be able to plan. You know how hard it is to find a new pediatrician in a dwindling supply? If a retiring physician is truly committed to the medical home that he or she helped to build, they will provide ample opportunity by which to find a replacement. And it requires a long time. And this is probably one of the more contentious things that I've ever brought up. And it's usually the older people who fight against it. But how can a practice truly have a succession plan if a partner can leave with 2 months' notice? That is not that's not an appropriate succession plan. And so that's why I like to penalize, I don't like to penalize people, but that's why I like to have this provision in there to protect the practice. There are some other things regarding coding compliance. If you have a partner who's billing 80% 99214s, you got a problem. And so, for sure, if they're billing 80% 99215s, you definitely have a problem. So how are we going to address this? We're going to assign some financial responsibility in a way that's legally valid, that the partner is going to assume it. Because what's going to happen is at some point you're going to get audited. And as best I know from this, and I've seen quite a few audits, is that they will do sample audit for an entire practice. And based on the sampling, they say, you overcoded this % of the time, which had this, they extrapolate some numbers, and basically they're going to discount all future payments to the practice by that percentage. But it's all because one knucklehead wasn't following proper E&M guidelines that the whole practice is affected. So we need to assign some responsibility to that individual who created the problem. And so I like to do that within the shareholder agreement. There have been some situations where there are reasons for each of these items in here, but these are things to think about as you move through and look at your shareholder agreement. The last math problem we're going to run through today from me is, let's assume that I have a pediatric practice. Dr. Hart wants to buy in. I go to him and I say, the price is $400,000. You want 50% of my, you want to buy into the practice, or you want to purchase the practice from me? He's got to pay $400,000. So he can commit to $100,000 a year coming to me, and is that a good deal? If you run the math, it's a heck of a deal. And the reason is because when we do some numbers, we're able to look at it and take the long game and say, look, Dr. Hart has been making a salary of about $160,000 a year, as represented in column A. Because he's now a partner, it makes about $125,000 a year in profit. Even after paying me for the practice $100,000 a year, he's still netting out ahead. But more importantly, he can practice another 10 years. And so the long game is really incentivizing, even for the skeptical young people who may be scared off by an appropriate value that you're offering for them to buy into the practice. And so I encourage you to think about this, is if the proper value of your practice is scary, you may need to do some math to walk them through to show why it's a good return on investment, so that they agree to buy into the practice for the reasons that you need them to. So 9 times out of 10, it's a sweetheart deal for the person buying in. And don't get discouraged, because there is usually a path by which to show the financial rewards and return on their investment. a couple times a week, I'll get an email from somebody saying, hey, can you send me a spreadsheet on how to do this? Sure, no problem. And I ended up sending all these spreadsheets. And I said, you know what, I'm gonna put these 3 dozen spreadsheets in one place, and if anyone asks, I'll just send them the link. I'm sharing with you the link of spreadsheet that we use on a weekly basis, sometimes daily, and it had a whole smattering of different things, from budgeting to all the bonus calculations that I showed you a few minutes ago, key performance indicators, a summary sheet to abstract your managed care contract, a whole bunch of stuff. So please feel free to use it and download it and use it to help you to develop a budget. There are some sheets in there that help you to think through in 5 pages how you should be preparing a budget for your practice. There's also on the PMI website a thing that walks you through that. So these are the kind of tools that we want to help you so that you're empowered and feel comfortable taking charge of the financial condition of your practice. In the last couple of minutes, I do want to share some thoughts that directly correlate to the culture that we talked about earlier. Can you imagine a railroad track that is parallel but 1 degree off? And that every mile that railroad track goes another degree and another degree and another degree? Over time, on a long enough stretch of road or rail, what happens? They become so wide and the train gets derailed. I can look from here to the end of the room, they look perfectly straight. But I need 100% alignment along that whole path of the rail in order for that train to be a viable delivery vehicle. Is your practice 100% aligned? Is there a disconnect between the partners? How is that having an effect within your practice? And so we encourage people to think about things and have those open conversations and make sure that you're aligned not just in how much is the financial value of the practice, but your commitment to a medical home. Ask yourself, why? Why are we doing these things? What are we doing with the culture? Because we need to be thinking about, in order for a pediatric practice to be successful, they must be 100% aligned. And they do that by A, providing the best possible care, 2, set reasonable expectations of themselves and their employees, and then they hold people accountable. The biggest failure I see, or the biggest dysfunction within pediatric groups, is when partners don't hold each other, hold reasonable expectations and hold them accountable. And so here's an opportunity for you to think about within your own practice. Do we have open conversation with partners to ensure that we are 100% aligned? Does your strategic plan fit your financial and operational objectives? These are the kind of things that best performing practices that we know are thinking about how things are aligned, and it's really driven by your culture and your values. And as I wrap this up, I ask you to not forget about your family. My father was a practicing pediatrician. I know what it is on that side of the fence, but each of you pediatricians here in the room also need to think about how your decision and your running of the practice affects not just your partners, your employees, and your patients, but how it also affects your family, your ability to provide for them, your ability to be there for them as well. So plan for the future. Develop an appropriate model based on the culture and values of your practice. Think about who's going to step in when the unexpected arrives, and develop that plan. And by thinking through these things within your own practice and assessing your own partners, it gives you the ability to think strategically to guarantee the success and viability of a medical home for children. And this is your second round of homework. I think earlier there was some homework that was assigned to you. These are some things to think about while you're driving. Did your buy-sell agreement provide the details that explain what will happen in different scenarios? Do you have a contingency plan? Do you have the resources in place? Have you looked at alternative corporate structures that give you the flexibility to effectively ensure the viability of your practice? Are the goals, your own personal retirement goals, being met by the course in which the practice, the direction of your practice? And, you know, has the business been properly valued? Because one day, everyone will be retiring or have to depart from their practice. And I wrap this up by reminding you of the story of my father. The principles that they laid down 23, actually it was closer to 35 years ago that they laid down the principle, but they followed through on the plan 23 years ago, and the plans and the guidance are still applicable today. Think about your future, make a commitment to planning, because we know it's gonna happen. And whether it's an internal buyout, selling to a third party, or whatever, you really need to take the time to think through in order to ensure the legacy that you have built. I'm always available, probably a little too much by some standard. You can zap that and it'll, I don't use this slide very often, but you can zap that and it'll bring you to my calendar. I'm happy to talk to anybody. Anyone who knows me will know I'll talk to a fence post, so you just may be the fence post for that hour. But I welcome the opportunity to talk with you if there's any questions you have. I hope that you find that the spreadsheets will be helpful. I'm going to end it on that slide in case you want to take a picture of that. And I appreciate everything, and I don't think anyone fell asleep, so that's a good thing. Great, thank you.
Thank you, Paulie. We're about to head into a 15-20 minute break. There'll still be refreshments. If you have questions, Paulie will be there and able to answer things. I want to thank Paul for his expertise. In fairness, I would say this is maybe over our 26 years, one of the most detailed financial discussions or presentations that we've had. For those who aren't quite ready, it may be a little overwhelming, but quite frankly, the first step is beginning to sort of appreciate that practices mature, people come and go, and we need to sort of have a plan and a business model in place that is fair to you and fair to your partners and fair to your practice colleagues to make things work. And so I appreciate Paul being able to provide sort of the framework and overview, but there's always more opportunity to keep learning. And there are other practice management sessions around the country where you can get additional information, but remember, we're going to be back here this same time next year to be doing more of this. So we have a 20-minute break, and then the final presentation, Chip's going to wrap things up. We get presented with a lot of information. Chip's topic is going to be about actually putting change into practice so that when we leave and go home, it's like, oh yeah, that was pretty good, but then we go back to business as usual. There are ideas and ways and strategies to begin to put some improvements into place. So we're going to regroup around 3:15 and take it home. Thank you so much for your participation and active listening. We'll see you all 3:15. Thanks.